You have just had a baby. And everyone around you, the nurses, the family members who have come to visit, the strangers who stop you on the street, keeps telling you what a joyful time this is. What a gift. How lucky you are. And you cannot stop thinking about all the ways the baby could die. You check the breathing monitor 4 times before you can get into bed. And then you cannot sleep anyway, because what if the monitor malfunctions? You run through every scenario: SIDS, overheating, the angle of the neck. You replay the feeding from 3 hours ago wondering if you missed a cue. You imagine car accidents on every drive. You call the pediatrician for the 3rd time this week about something that you know, somewhere underneath the fear, is probably fine. And here is what no one has told you: this is not just the normal intensity of new parenthood. This is postpartum anxiety. And it is affecting approximately 1 in 5 new parents. And it is underdiagnosed, undertreated, and insufficiently discussed, because the cultural conversation around the postpartum period still centers almost exclusively on postpartum depression, leaving the parents whose primary experience is anxiety without language, without recognition, and without the support they genuinely need and deserve. This video is for them. For you, if you were in it. For the partners and caregivers who are watching someone they love disappear into a spiral of fear and don't know what to do. And for the therapists and healthcare providers who work with perinatal clients and want a complete, clinically precise framework for one of the most under-identified conditions in their population. A comprehensive cheat sheet covering everything in this video is linked in the description. Let's begin. Section 1. What postpartum anxiety actually is. Postpartum anxiety, PPA, is a clinical anxiety condition that develops in the postpartum period, typically within the first 12 months after the birth of a child, though it can emerge during pregnancy as perinatal anxiety and can persist or recur with subsequent pregnancies and births. It is characterized by persistent, excessive worry and fear that is disproportionate to the actual level of risk involved, and that causes significant distress and interference with functioning. The DSM-5 does not list postpartum anxiety as a standalone diagnosis, which is itself part of the problem. It is most commonly captured under generalized anxiety disorder, with the postpartum onset specifier, or under the broader category of perinatal mood and anxiety disorders, which encompasses the full range of mood and anxiety conditions that can emerge in the perinatal period. This diagnostic ambiguity has contributed to the underrecognition and undertreatment of PPA in clinical settings, and it is an active area of advocacy in the maternal mental health field. What the research does clearly establish is its prevalence. Studies consistently find that postpartum anxiety affects between 15 and 20% of new mothers, making it more common than postpartum depression, which affects approximately 10 to 15%. When fathers, non-birthing parents, and adoptive parents are included, the numbers remain significant. PPA is not rare. It is one of the most common complications of the postpartum period. And yet it is routinely missed, in postpartum checkups that screen for depression but not anxiety, in cultural narratives that frame constant worry as just what responsible parents do, and in the minds of the people experiencing it who have internalized the message that their anxiety is vigilance, not illness. The distinction between PPA and postpartum depression is important clinically and experientially, because many new parents dismiss the possibility that they need support by measuring themselves against the PPD picture and finding they don't match. They are not depressed. They are not sad, they are not unable to bond with their baby, they are not withdrawing from life in the ways that PPD is classically described. They are terrified. Constantly, exhaustingly, inescapably terrified. And that is a different presentation that requires specific recognition and specific support. Section 2. PPA versus normal worry versus PPD, the critical distinctions. 3 distinctions matter enormously for anyone trying to understand their own experience or support someone else through this, and getting them right changes whether the person gets appropriate help or continues to minimize, dismiss, or misidentify what they are experiencing. The first distinction is between PPA and normal new parent worry. Normal worry in new parenthood is real, appropriate, and in many respects adaptive. New parents are responsible for a completely vulnerable human being who cannot communicate their own needs and who requires vigilance to keep safe. Some degree of heightened alertness, careful monitoring, and concern about risks is not pathological, it is parental attunement. The difference between normal worry and PPA is one of proportion, persistence, and impact. Normal worry is responsive to reassurance and resolves when the specific concern is addressed. PPA does not resolve with reassurance, the relief is temporary and the worry quickly finds a new object. Normal worry does not significantly impair sleep, functioning, or quality of life. PPA does. Normal worry does not involve intrusive images of harm or catastrophe. PPA frequently does. If the worry is constant, resistant to evidence and reassurance, disruptive to daily functioning, and causing significant suffering, that is not normal new parent vigilance. That is postpartum anxiety. The second distinction is between PPA and PPD. These conditions can co-occur, and frequently do, with studies suggesting that up to 50% of people with PPD also meet criteria for an anxiety disorder. But they present differently and they require somewhat different emphases in treatment. PPD is characterized primarily by persistent sadness, low mood, loss of interest or pleasure, feelings of worthlessness, difficulty bonding, and in severe cases, thoughts of self-harm. PPA is characterized primarily by excessive worry, fear, racing thoughts, physical tension and restlessness, hypervigilance, and often intrusive thoughts about harm coming to the baby. The person with PPA is frequently engaged with the baby, often hyper-engaged, unable to let anyone else manage the baby's care because the anxiety convinces them that only they can keep the baby safe. This can look, from the outside, like intensive mothering or fathering. It is experienced, from the inside, as relentless terror. The third distinction, important for clinical screening, is between PPA and the baby blues. The baby blues are a near-universal experience in the first 2 weeks postpartum, emotional lability, tearfulness, irritability, and mood instability driven by the dramatic hormonal changes of the immediate postpartum period. The baby blues resolve on their own within 2 weeks without intervention. PPA does not. If significant anxiety is still present 2 weeks after birth and is not resolving, or if it emerges or intensifies after the initial postpartum period, this is not the baby blues and it warrants clinical attention. Section 3. The biology, what's happening in the body and brain postpartum anxiety does not emerge in a vacuum. It develops in the context of one of the most dramatic biological transitions the human body undergoes, and understanding the biological substrate of PPA is essential both for removing the shame that surrounds it and for understanding why it requires more than simply trying harder to calm down. The hormonal landscape of the postpartum period is characterized by a precipitous drop in estrogen and progesterone, the two hormones that have been at dramatically elevated levels throughout pregnancy, within the first 24 to 72 hours after birth. This hormonal withdrawal is among the most rapid and dramatic endocrine shifts in human biology. Both estrogen and progesterone have significant modulatory effects on the neurotransmitter systems that regulate mood and anxiety, including serotonin, GABA, and dopamine. The withdrawal of their influence creates a period of neurochemical vulnerability in which the anxiety regulatory systems of the brain are operating without the buffering effects they have been relying on for 9 months. Cortisol, the primary stress hormone, remains elevated in the postpartum period relative to pre-pregnancy baseline, driven by the sleep deprivation, the physiological demands of recovery from birth and potentially from breastfeeding, and the genuine demands of newborn care. Chronically elevated cortisol sensitizes the amygdala, the brain's threat detection center, making it more reactive to potential threats and lower threshold for activation. The postpartum brain is, neurobiologically, an anxiety-amplified brain. The threat response system is running hot because the biological conditions of the postpartum period reliably produce that outcome. The neurobiological function of maternal anxiety is worth acknowledging explicitly, because understanding it helps with the destigmatization that is essential to PPA recognition. A moderate degree of heightened vigilance and threat sensitivity in the postpartum period is not a malfunction. It is a feature, the neurobiological sharpening of attention to potential threats to a vulnerable offspring. What PPA represents is this adaptive heightening gone beyond its functional range, the dial turned up past the point where it serves protection and into the territory where it causes suffering and impairs the very caregiving it is trying to optimize. Thyroid dysfunction, which is common in the postpartum period, postpartum thyroiditis affects 5 to 10% of women, can produce anxiety symptoms that mimic or exacerbate PPA. This is why a thorough postpartum workup that includes thyroid function is part of good clinical care for postpartum anxiety symptoms. The biological contributors are real and they are treatable. And treating the biology is not separate from treating the psychology, it is part of the same comprehensive care. Section 4. How PPA presents, the full symptom picture. One of the reasons PPA is so frequently missed is that its presentation is broader and more varied than the cultural picture of anxiety suggests. Anxiety is not always visibly nervous energy or obvious worry. It presents across cognitive, physical, behavioral, and relational dimensions, and recognizing the full picture is essential for identification. Cognitively, PPA presents as persistent, excessive worry about the baby's health and safety, feeding, breathing, development, every cough and variation in sleep pattern. But it also presents as worry that extends beyond the baby to encompass the parent's own health, the relationship, finances, the future, work, and a general sense that something terrible is about to happen without always being able to specify what. Racing thoughts, the mind cycling rapidly through worried scenarios without settling, are characteristic. And intrusive thoughts deserve specific mention. Many parents with PPA experience unwanted, frightening images of harm coming to the baby, the image of dropping the baby, of the car crashing, of the baby not waking up, that arrive without warning and produce intense distress. These intrusive thoughts are not desires. They are the anxiety system generating threat scenarios. They are common in PPA and in OCD presentations in the postpartum period, and they are profoundly misunderstood by the people who experience them, who frequently keep them secret out of fear of what they might mean. Physically, PPA presents with the full range of anxiety's somatic expression: muscle tension, particularly in the neck, shoulders, and jaw, heart palpitations, gastrointestinal disturbance, headaches, fatigue that exceeds even the expected exhaustion of new parenthood, and difficulty sleeping not just when the baby sleeps, but when sleep is genuinely available, lying awake, mind racing, unable to turn the alarm system off even in the absence of an immediate trigger. Behaviorally, PPA often manifests as hypervigilance in caregiving, constant checking, difficulty delegating the baby's care to partners, family members, or caregivers because the anxiety insists that only the parent can keep the baby safe. It can manifest as avoidance, not driving with the baby, not going to places where the anxiety identifies risk, not leaving the house. And it can manifest as reassurance seeking, repeated calls to the pediatrician, repeated Googling of symptoms, repeated requests for partners or family to confirm that everything is okay, all of which provide temporary relief and long-term maintenance of the anxiety cycle. Relationally, PPA takes a significant toll on partnerships and on the parent's broader support network. The hypervigilance can feel controlling to partners who do not understand its anxious source. The constant worry can be exhausting for family members who do not know how to help. The shame that surrounds the anxiety, the sense that a good parent should feel joy rather than terror, often leads to concealment, which means the person with PPA suffers in isolation without the support that would make a meaningful difference. Section 5. Risk factors and who is most vulnerable. While postpartum anxiety can affect any new parent regardless of background or circumstance, research has identified specific risk factors that increase vulnerability, and knowing these is clinically important both for prevention and for identifying the people most in need of proactive support. Personal history of anxiety is the strongest single predictor. A person who has experienced clinical anxiety at any point in their life, whether diagnosed or not, is at significantly elevated risk for PPA. The postpartum period's biological vulnerability intersects with a nervous system that already has established anxiety patterns, and the combination is reliably potent. For people with this history, proactive mental health support beginning in pregnancy rather than waiting for symptoms to emerge postpartum is one of the most evidence-based preventive interventions available. A history of trauma, including pregnancy loss, infertility, traumatic birth experiences, childhood trauma, or abuse, significantly elevates PPA risk. Traumatic birth experiences in particular can produce a presentation that blends postpartum anxiety with PTSD features, intrusive memories of the birth, hypervigilance during medical interactions, avoidance of reminders of the birth experience, and a nervous system that has been in sustained activation since a delivery that felt life-threatening or out of control. This presentation requires specific trauma-informed care alongside PPA treatment. Inadequate social support is among the most consistently identified risk factors across the research literature. The postpartum period is one in which human beings are biologically designed to be held within a community, supported, assisted, witnessed, relieved. The isolation of contemporary parenthood in many Western contexts, the nuclear family expected to manage a newborn largely alone, without extended family, without village, is both a cultural failure and a mental health risk factor. The parent who is physically and emotionally alone with the anxiety has no co-regulatory resources to draw on, and the anxiety compounds in the silence. First-time parenthood carries elevated risk, as does the transition with a premature or medically complex infant, twins or higher-order multiples, or an infant with significant feeding or sleeping difficulties. All contexts that provide the anxiety with abundant realistic material to organize around. And socio-economic stressor, financial insecurity, unstable housing, lack of paid parental leave, the pressure of returning to work before the parent and infant are ready, are both risk factors in their own right and amplifiers of every other vulnerability already present. Section 6, Treatment and Support. What actually works postpartum anxiety is highly treatable. This is not a platitude, it is a clinical fact grounded in robust evidence. And it is a fact that needs to be stated clearly and repeatedly, because one of the most significant barriers to treatment seeking in PPA is the belief that this is simply the new reality of parenthood, that nothing can be done, or that seeking help is an admission of failure as a parent. None of these things are true. Cognitive behavioral therapy adapted for the perinatal context is the most evidence-supported psychotherapy for PPA. It addresses the cognitive distortions that fuel the anxiety, the catastrophizing, the probability overestimation, the emotional reasoning, alongside the behavioral patterns, particularly avoidance and reassurance seeking, that maintain the anxiety cycle. CBT for PPA gives parents specific skills for examining and challenging the anxious thoughts, tolerating uncertainty, and gradually reducing the hypervigilant behaviors that are maintaining the alarm system in a state of chronic activation. Mindfulness-based cognitive therapy, MBCT, has growing evidence for perinatal anxiety and offers the specific benefit of teaching parents to observe anxious thoughts without being commandeered by them, a skill that is particularly valuable in a context where the intrusive thoughts of PPA, so distressing and so frequently misinterpreted as meaningful rather than as symptoms. Learning to say I am having an anxious thought about my baby rather than my baby is in danger changes the relationship to the thought in ways that reduce its emotional charge and interrupt the spiral. Medication is a legitimate, evidence-based option for PPA, particularly for moderate to severe presentations where the anxiety is significantly impairing functioning. SSRIs are the first-line pharmacological treatment and several are considered compatible with breastfeeding, though the decision requires individualized discussion with an OB/GYN or psychiatrist, who can weigh the specific risks and benefits for the individual parent and infant. The message that medication is available and is not incompatible with good parenting or with breastfeeding is one that many parents need to hear explicitly, because the stigma around postpartum medication use is significant and frequently prevents people from accessing effective treatment. Social support interventions, peer support groups, postpartum support communities, home visiting programs, have strong evidence for reducing PPA severity and are particularly valuable in addressing the isolation that is both a risk factor and a maintaining condition for the anxiety. The experience of being with other parents who understand, who name the same fears without flinching, is not merely comforting. It is clinically meaningful. It provides the co-regulation and the reality testing that the anxious postpartum brain needs and cannot generate alone. For partners and caregivers, the most important thing you can do for someone with PPA is not to fix the anxiety, which is not in your power, but to reduce the conditions that amplify it. Concrete practical support with infant care reduces the physical and cognitive load. Consistent, non-judgmental presence reduces the isolation. Not providing reassurance in compulsive ways, while still being warm and emotionally available, helps interrupt the reassurance-seeking cycle that maintains the anxiety. And actively supporting the person in accessing professional help, normalizing it, facilitating it, going together if needed, may be the most important thing of all. The comprehensive cheat sheet in the description covers all of this: the signs, the risk factors, the distinctions, and the treatment options, in one organized, accessible reference for parents, caregivers, and clinicians. If you are in the postpartum period and the worry will not stop, if you are checking the monitor for the 4th time tonight, if the intrusive images of harm have been arriving uninvited, if the joy that everyone tells you should be there is buried under an exhausting, relentless fear, please hear this: what you are experiencing has a name. It is not a reflection of how much you love your baby. You are probably more terrified precisely because you love this person more than you have ever loved anyone. It is not evidence that you are a bad parent or that you are failing at this. It is a clinical condition, produced by a set of biological and psychological circumstances that converged in the postpartum period, and it is one of the most treatable conditions in all of perinatal care. You do not have to white-knuckle your way through the first year of your child's life. You do not have to earn the right to ask for help by being worse than you currently are. The anxiety you are experiencing right now is enough. It is more than enough. And there are people, OB-GYNs, midwives, therapists, psychiatrists, perinatal mental health specialists, who understand this condition, who are trained to treat it, and who can help you find your way back to a version of early parenthood that has more room in it for something other than fear. The cheat sheet is in the description, for you, for your partner, for your provider, for anyone in your circle who needs to understand what postpartum anxiety actually is and what actually helps. Share this video with a new parent who might need to know they are not alone in this. And I will see you in the next one.